Okay, thank you for the invitation and introduction. I have to first apologize twofold. The presentation is built on several presentations of the last decade, so not all slides are very similar, and so it's a bit patchwork. And the other, as you heard, I come not from Oxford, so I come from Bern, Switzerland, and my English, I hope you can follow the presentation and must not count all my mistakes. I'm Gere Luder. I'm physio since 1997. Made then a Master of Science, a bit late because in Switzerland that's not so easy. I did just before research at the biomechanics lab of ETH, that's the Technical University of Switzerland in Zurich. And since 2003, yet a long time, I'm at the Bern University Hospital, also mainly in researching, currently 50% position. And I'm PhD student at the end of the journey nearly, so that the study that I show at least is my PhD project and is finished, and now the data analysis will follow, and hopefully next spring I will defend my thesis. I'm also teaching in a bachelor curriculum at the Bern University of Applied Science. When I have time I'm running a little bit, and one of my signs is that I have always two different shoes, so that's a bit of a funny thing that I wear with me also since 20 years. So hypermobility, we always start our talks with such an image and say, okay, as you all know, hypermobility can be a friend, can be very positive, especially for sports or for some artistic things to do, but it can also be a problem, what we can see in our patients. So that's the big question, when it's friend, when it's foe, and what are the factors that decide if you can cope with your hypermobility or if you cannot. So that's mainly then the thing. So this information is just the background as we use it normally. We mainly look at women because women are more often affected, and it's more easier when you have a homogeneous group, so all our studies were just with women. Also we have women from 20 to 40, so there's a decrease with age, so we don't want the older women, also because of the hormonal changes that will also influence some things that will complicate the results. We are mainly based our studies on Baton score, so we were always a bit in a middle position to look at benign generalized joint hypermobility, where we started mainly, or do we then more go to joint hypermobility syndrome, where we are also on the way. But the Baton score, that's the main thing. We included our patients' Baton score high or not. So that's an overview. We started with a pilot project, 2005, with a cross-sectional study with 31 women. Then we, from this, planned a larger trial, also cross-sectional, with 195 women, where we measured several things to look what's the difference between normal mobility and hypermobility. And the third thing now is this RCT, where we looked at the effect of strength training in hypermobile women. So we started more with the idea of what is the active and passive tone, what's the influence on mobility and hypermobility, came then more to the symptoms, functions, and then now we are in the resistance training. So we made this pathway a bit from the biomechanics and are now more clinical, but still interested in the biomechanical part. Just as a bit of background for this, the big question for us was then, and is still, how much flexibility is optimal. So mainly there's some range of motion that is optimal, that is good, where you can control your movement, where you have no pain, where you can do what you want. You can have too less flexibility, you can be stiff, and some limitations, and that is well known in physiotherapy. We have a lot of mobilization techniques, we have a lot of things to improve range of motion, so that is well good established. But the other thing, the question is, can you also have too much flexibility or too much range of motion? So the hypermobility clearly shows there is a way you can have too much, but it's little knowledge about what does this implicate and what do we do with these persons. So in this range, anywhere is the optimum, and the big question is what is it and what are the determinants of this. So maybe this will also be different for every joint, not similar in the back as in the knee or in the shoulder or in the fingers, depending on age. Surely there's a change with age, and that will also change your demands on mobility. So mainly in the higher age you have less demands, not always, but maybe, depending what you want to do on sports or also daily life activities. How high is your cupboard where you have to take the cups? So depends what you need to on mobility, and many other factors. And just to show a little bit, we do also other things. One example of another study I was involved in is the curves of range of motion after shoulder surgery. So they just looked in different groups with fractures, with rotator cuff refixation, with prosthesis, how is the range of motion several weeks after the surgery. You can see, especially here, this elevation, okay, that increases, that's nice, and the rotator cuff, they come to 140 degrees of elevation. The prosthesis just 120, but the question remains, is this enough, or is this enough, or should they be at 160? Or the most famous Swiss guy, he would be not happy with 140. Roger Federer, he needs mainly a bit more, but okay, these are all the people. But still the question is, where should they be at the end, and what should they reach? Or another thing, that you can also cope with less mobility, or too less. That was a study at ETH years ago, where we looked at patients after knee prosthesis with limited range of motion. So the red circles is the normal range when you go stairs up and down. And these are 4 persons with limited, you see the knee flexion range, and you see that even with 75 degrees of knee flexion, passively measured, you can walk stairs, and that works. But okay, he comes then up anywhere below 70, or when you have even 80, he comes then just to 50 degrees of knee flexion. So even if he has much more range, he doesn't use this, so he reduces still, but he can reach his aim, he can walk the stairs. So how much is enough? Maybe also with 75 degrees you can walk the stairs, that's okay, but normal would be more. So these are some background things we thought about and think always a little bit how to do with this. But okay, back to our project. As I said, we started with more the biomechanical idea. What is normal movement? What are the influences for this, especially for active and passive structures? So we looked at active tension, one side, strengths you have in the muscles, sensory motor function, how can you control actively your movement, and then on the other side, the passive tension, the passive control mechanism, capsule, tendons, ligaments, muscles, vessels, nerves, even skin, all will in one way influence your range of motion and restrict or allow more movement. So we, for this pilot study, had the idea to look at which parameters of active and passive tension are different in women with hypermobility and in women without hypermobility, regardless of symptoms, just hypermobile or not. We made this cross-sectional study with women, as I said, 18 to 40 years, normal BMI. The hypermobile group, we always choose 6 as a cutoff, even when 4 was once the suggestion, but newer papers say also that 6 is better, so we looked at Baton score higher than 6, and we also, that's not noted normally, looked at they have at least one hyperflexible, hyperextensible knee, because all our measurements are on lower leg, mainly on the knee. So we wanted not the person that can just bend the fingers and the elbow, have 6 points, but the knee is stiff as anyway, so they should have knee or the palms flat on the floor, that they really had also hypermobility on the legs. We excluded people with pain or traumas in the last 2 years. Pregnancy was excluded, and also the more severe connective tissue things we excluded, so that we had really just a hypermobile women. We measured then for active tone the angular movements, surely, cross-section and diameter of thigh muscles by ultrasound, then also stretching, tension with a special device. I will show this later a little bit more, and also stretching, tension during tibial translation. That will I also show you then afterwards a bit more in detail. And on the active side, we looked at maximum strength and rate of force development of knee exters and flexors, and on one-legged standing with and without eyes closed. So these were the participants, small group, similar except for the Baton score, for sure, and usually they differed in flexibility. That was to be expected. There's difference. Interesting is this difference in the straight leg raise manually measured. So we looked at this manually. There was a huge difference between these two. Can keep this for later. Then in the ultrasound measurements we also found some differences, that they showed less muscle diameter, less muscle area, the hypermobile in some terms, especially for the rectus and the biceps femoris, not so for masters lateralis and medialis. So there was some difference in muscle diameter, maybe also then muscle mass. And then the interesting thing or funny thing was then that this difference in straight leg raise passively measured could not be reproduced on this device. So the angle here was more comparable. So the hypermobile, they got not so wide as in the passive thing. And torques and angles at several positions, that was all the same. So there were differences, but they were not significant. So there was more a problem of huge standard deviation we had. So especially here you see torque at 20 degrees of hip flexion. That was a huge standard deviation. So that was a bit the problem, that it got not significant. Similar for tibial translation. There was a tendency for a difference, but not at all. As I said, I come back to these measurements in more detail in a second. The active tension. For the balance, there was a difference in mediolateral sway. So they had a higher excursion mediolateral, the hypermobile women, and in the terms of strength, there was only a difference in rate of force development, where they had a higher rate of force development, so they could quicker activate their muscle. But the maximum force that was comparable between the groups. So these were some results, some surprising, some we expected, and we discussed a lot about what this does mean, and found some things, but okay, not very much. The hypermobile women, they have a higher flexibility, they have reduced muscle diameter, this higher sway, this higher rate of force development. But the smaller muscle diameter that we measured did not correlate with the stretching resistance in this straight leg raise test. There was also not a correlation between the muscle mass and the stiffness, what others, as Markussen and others, proposed, that the more muscle, the more stiffness you have. So that was not the case in our study. And this bigger passive range of motion in the passive straight leg raise could not be reproduced with the device. So in the active side, the smaller diameter, no difference in maximum strength, high rate of force development. There's the question, is this some kind of compensation mechanism to gain more stability when you can quicker activate your muscles? Maybe, maybe not. We postulated that then. In the later study we could not reproduce this, so that's a bit the problem. So concluding, we said there are some parameters discriminating, but these are quite weak. They exist, but they give not the real clue. This was published in 2008 in ACR, And note, this is Christine. She called her then Mebes. Now she's named Müller. That's the same person that she married in the meantime. So the publication is still from her. Okay, a bit more to these biomechanical measurements. For these both studies, we looked at these. Ultrasound, we also called because we looked there at muscle diameters. Then this isokinetic device, this tibial translation, and in the new study we have looked then also at PQCT with also to measure muscle diameter, muscle cross-sectional area. So this device is a quite funny thing. It was built once by some bachelor students together with an engineer. It's a machine that can passive elevate the leg. The participant controls this with this joystick, so can there move and go back. And there's a pressure measurement here at the Achilles tendon, and then you can calculate the distance and the resistance and do so resistance force curves and look what is the resistance of the leg. We found no difference, as I showed before, in this between hypermobile and normal. We expected large differences, so we looked what are the problems, and one of the problems was the knee extension, because we noticed then that these hypermobile women, they, as more as you lifted, as more they extended the knee, and on one side that did not go so far then, because maybe once the knee was too much extended even for those, and on the other side the pressure mainly goes then also in this knee passive structures and not here on the Achilles tendon. Maybe, so these are some explanations. So we tried then to improve this fixation even with cost and all, but it was too difficult, so we did no longer use this device, even if it would still be a very interesting thing to do, especially not for these patients, but also for others it's quite difficult to use this, but it's interesting. So we switched to another a bit easier thing, that is the measurement of tibial translation with an adapted air-cast rollimeter. So that is here, we built in here a rollimeter that measures the distance here with a computer. Put the leg on a kinetech device in 50-degree flexion, and then made an anterior drag with this sling and the force transducer, and measure here the distance that the tibia moves forward or upwards, or as you want to say, and look there which distance, which force do you find in this. The paper of this is submitted, but it's somewhere in the pipeline. We do not know. We ask every 3 months, but not so much reaction, so we hope it will come. So we have then this curve of the translation and the force, and we expect that for the hypermobile women this curve would be shifted here to the left, so that the more translation with less force. We made then some calculations of the maximum force you have. That was more for control, but it was not different. Then the maximal translation, maximal distance is also interesting, but not so much important, we think. More interesting would be these forces at 40 and 80 newtons. So when you just have small forces or medium forces on the knee, how much do you move your tibia? How much does the anterior cruciate ligament, that is mainly, does it stretch? So we look mainly at these things at 40 and 80 newton. And we made this also with the large group. Here just the results to look a bit forward. For the maximum, there was no significant difference. A bit the tendency for a longer distance, but these 2 points at 40 and 80 newtons were significantly different between the both groups. So really this curve is shifted, and the hypermobile women, they showed more way with the same force. So they have some kind of laxer ligament there, so that was also to be expected, but it's always important also to look if it's really the case. But also we notice large standard deviations and the large variation in the group. So we came then a bit away from these biomechanical things and wanted to also look more at symptoms and problems in daily life together with the biomechanical. So in this large study we made really also much measurements. We looked at gait analysis, ground reaction force and DMG, not kinematics. We looked at stair climbing, also ground reaction forces and DMG, tibial translation as I've shown. We looked also at balance. We made then an assessment, the Canadian Occupational Performance Measure. That's an assessment from the OTs, where you ask in a kind of semi-structured interview, where do you have problems in your daily life and what kind of problems do you experience. And we made also follow-up for symptoms, even for those that they mentioned there. So we tried to assess all levels, the impairment, the function, participation, that we had all a bit inside. Same inclusion-exclusion criteria as in the first study, so that was not different. And the thing we added was this symptom questionnaire. So we took 3 defined symptoms that we preset, that was lifting, weight over 10 kilo, walking stair down, and holding a position more than 20 minutes. These were the 3 first, and then the 4th and the 5th 2 additional functional movements were defined for each patient individually. So depending on this COPM interview, they noted there some throwing or typing or whatever they mentioned there as a problem. And then for 6 months, they had every month such a little questionnaire where they said, did I experience this in this month once, several times, how much, how important was it, how much pain, and where was the pain. So we tried a bit to look what are the symptoms also over time, because we thought a bit that it's just a one-time look at the symptoms, because many of the women, they said, yeah, sometimes I have pain and other times it's quite well. So depending on what they do, depending on maybe other factors, even hormones or whatever, stress in daily life, it gives more pain or gives less pain. So just at one moment look, do you have pain? That's maybe not the really good thing. So we tried to do this with the 6 months follow-up. These are the participants in this study. A bit crowded, I know, but the important thing is just all participants were 195, divided in 2 groups according to this Baton score. 67 with normal mobility, Baton 0 or 1, and 128 with Baton 6 or more. And then these hypermobile we divided according to the symptom questionnaire in some with symptoms, some without symptoms, and the third group we could not classify because they did not return the questionnaire. So and these are then just these other groups. We also looked then at 2 comparisons. We compared these 2 groups with a t-test, and we looked at these 3 groups with and without symptoms with INOVA. So that was just a different approach for the statistics. So here I will not show all the results, but just some examples. The stair, because that's was my main interest. I also did with this my master thesis. Stair descent is a important activity, also a quite difficult activity when you look at ground reaction forces, because that's 160% of body weight, you reach the maximum, and that's about 140 milliseconds after touchdown you have this maximum, so you should have quite good stabilization, quick muscle fibers or passive structures, whatever, but something should help you to stabilize this large impact in this short time. So we wanted to measure the muscle activity and also ground reaction forces to look at this. And then we always make these questions once is there a difference between women with normal mobility and hypermobility? And the other thing, is there a difference between women with symptoms and women without symptoms? So these were always a bit the two different things where we looked at. And this was this cross-sectional study, was supported by the Swiss National Science Foundation. For the stair, we had the 6 steps there that we use also in other projects. They made 10 trials, up and down, ground reaction forces with a force plate, integrated in the step, and 6 muscles, both vasty, the 2 hamstrings, and gastrocnemius and tibialis anterior were measured. And we derived some parameters from the ground reaction forces. This maximum peak, the height and the time, then the total contact time were the main parameters, and for muscle activity we normalized it to maximum voluntary contraction, made some linear envelopes and looked there also at the maximum activation and mean activation during stance phase, and took there also the means from 6 steps of these 10, so that the middle 6 normally we took for the ground reaction forces and for the EG. So in the ground reaction forces, nothing was to see. The curves look quite good and normal, and there was no difference between all these groups, weathering stair up, stair down, so that was quite normal. So in the total, the ground reaction force is some kind of impression of the total movement, so that's the result of all what you do inside your body when you go down, up, and down. So there they should reach the same goal as the people with normal mobility, so no difference in the global pattern. Also in the parameters there were no differences, that was all normal. For the muscle activity we found then that the hypermobile women had lower activation in several muscles. So first there up in muscles medialis and lateralis was lower, and also in the women with symptoms the muscles medialis was still lower. That was not always significant because the groups were smaller, so that was then, but the tendency was the same. So quadriceps was lower in the stair up, and in stair down also quadriceps activation was lower, not so big difference, but additionally semitendinosus also showed a lower activation in this, significant lower. These are just the significant values. When you look at the curves, you can clearly see there these differences are also there where the activation is, so it's not a difference anywhere in the low part, it's there where the important muscle activation is. So we think that it's really a difference that is important, especially here this first peak here, and here for stair down this stance phase in the middle where you should stabilize your knee. So that is a difference that can be also relevant clinically. These are just the numbers for these. So again, this lower activation for stair up and stair down. And when we conclude this, then we see stair up quadriceps was lower activated, and this is important because this quadriceps is the main stabilizer and the main muscle to lift your weight up concentric when you go up the stairs. So there they have had less activation, less muscle activation to lift this. And in stair down, it's both semitendinosus and quadriceps that were lower, and these are both there important for the control of the knee joint, because when you go stair down you have more to eccentric control the lowering of the weight, so there is more control function of the muscle, but also there that was lower in the hypermobile women. So maybe this lower activation, possible reasons are to avoid high forces. When you activate the muscle more, you have more joint pressure, more force, so maybe they want to avoid that because that maybe will give pain. Or they have inhibition of the muscles by reduced arthroception, because the laxity, they have not so much information from the joint, and that inhibits the muscle activation. Also maybe pain or even local swelling. We found a study that even a little swelling that you cannot clinically see introduced in the knee reduces muscle activation 10 to 20% in the quadriceps. So there were some signs, but again, differences were small. Maybe also this stair climbing activity is not so high demanding for these rather young women that there were large differences. So there were more tendencies to see there is some difference, but not so a large difference. It was also published then in Journal of Electromyography and Kinesiology, and similar paper with the adaptations in gait. That was mainly my colleague Stefan Schmid who analyzed this. Similar method, also this gait analysis, EMG around reaction forces, and he found, interestingly, that vastus medialis and lateralis were higher activated during gait, during stance phase. So there it was mainly in this stabilization phase where they had higher activation. So the activation is low, but even a bit higher in the hypermobile women for both. And also higher activation for the gastrocnemius medialis during strike, and also stance and at heel strike. So that was then mainly in this phase where the gastrocnemius is the important muscle that they had a higher activation. Lower was just semitendinosus. That was a little bit here at the beginning. But in these terms, in the gait, it seems more that they show a higher activation. These are also the numbers for this, but these findings, they go along with some similar results of Simonsen, where they found higher extensor moments, they found higher flexor moments during mid-stance, and also higher knee flexion. So, also similar mechanisms were shown with ACL deficient patients with the aim to gain stability, so possibly hypermobile subjects in gait, where you have normally very low muscle activations. There they increase their activation to gain more stability. During stair climbing, where you have normally very high activations, especially down, you saw that was nearby 100%. There, maybe it's a bit different. There, maybe they reduce to avoid forces. So we still have not the explanation for this difference, but there is a slightly different tendency to adapt in gait than in stair climbing. Maybe because these are two different difficult tasks. And just for finishing this, the COPM, just what they mentioned as problems, for short, pain was the most mentioned, instability was not so often, astonishingly, blockades of the joints and some others. These results we are still finalizing and try to publish, so this should come once. And the locations where they mentioned, that was mainly also the knee, what we saw, and the back, interestingly, also showed people with normal mobility showed back problems, so that was not just a hypermobile, so that was not so a large difference between these groups. Okay, we then had all this huge amount of data, and we also tried to look, or I tried to look a bit, what is the pattern in this, all these measurements. So I took the measurement, all the patterns, the parameters, totally 62 parameters of all these measurements, put them in one sphere, cooked. I did a principal component analysis, just with the two groups, hypermobile, normal mobile, to look if there are factors that are together that can differentiate between these two groups. So all factors with eigenvalues, more than one were extracted and looked which components were in. Also, that was not very very surprising, or it was disappointing but not surprising, because there were 17 principal components. So not very much reduction in this case. They did accounting for 80% of variance. Okay, that's not so bad, but 17 for 80%, it's not so much. Okay, I took the 5 most important factors that were then nearby 50%, but even 50% is not so much. And when you look at the first of these, it was 13% of variance explained by ground reaction force patterns. There was also because there were no difference in ground reaction force patterns, but anyway, something there came in this. Second was then balance and the muscle activation of quadriceps and hamstrings during gait and on stair. The third was the strength of the knee extensors and the balance, also balance parameters. The fourth was again muscle activation of lower leg muscles this time, strength of knee flexors and body weight and BMI. And just in the fifth position came then the more passive things, the range of motion of the knee, Baton score, and also this passive tibial translation. So this maybe shows a bit that passive things are not the most important, that active control is maybe more important. So to conclude, the PCA that did not reduce these variables on few factors, but 5 most could explain 50% of variance with several variables, and as I said, muscle activation is one point, passive range of motion is a point that comes quite late, so it's more a complex phenomenon and not just one-sided. So that was a bit of a confirmation what we yet knew, but it was here then with the numbers. And also the measurements in this study, they were probably not so enough demanding that the young woman really could be discriminated in these two groups. So to come to the end, the training study that is just now finishing, we looked there, that's just the overview there, we looked at the effect of strength training in these women and made again different measurements. There was collaboration also with the Department of Rheumatology and several co-workers. It was an RCT we did with a waiting list design, so we wanted to include 50 women, 25 training immediately, 25 waiting, and then training later. And the training phase was 12 weeks, with first few weeks with complex training, and then 10 weeks aiming at hypertrophy, so really training with 80% of 1 repetition maximum, 12 repetitions with series that they should do. They have training instructions the first, the third, and the 6th week, and otherwise they should do their training themselves in the gym of the University Hospital. These were the exercises: leg press, knee extension, hamstrings curls. So we decided to choose open and closed chain exercise so that we had both in hip abductors, gastrocnemius, and also 2 exercises for back and abdominals to a bit widen the area. And we measured several things: tibial translation again, knee muscle strength, stair climbing. The new thing was then this muscle cross-sectional area with the PQCT from the thigh and also lower leg, where we wanted to look if there is a change in muscle area, in muscle mass even, and we made also some questionnaires as the 36 aims to, and the pain and disability questionnaire we did ourselves because the Bristol questionnaire was not yet available. Exact. So I have now just the results of the strength and the PQCT measurements. These were the groups we had, similar in terms of age and height and these things. We looked also at Brighton criteria, and for it was not the inclusion point, but we looked to control. So we saw a third of our participants, they were Brighton positive, and 2/3 they were not, but mainly they were hard at the border, so also a bit difficult, we think, to decide when have you how much of these conditions by you. Contraception we looked also, was a little difference, and Baton was quite similarly between both groups. So we found, interestingly, the measurement with the PQCT was a difference, so they increased their muscle cross-sectional area. At the thigh, here significantly they increased more, the other also a little bit, but that was, it's always the difference between pre and post. So this is minus 25 to 118 is not a real difference, but they show the difference. They increased muscle area, muscle mass also measured on this. That's just on one point, but that was higher, but not strength. Strength was not different. There was the same. So this is submitted for the EULAR. So I will come back in June, hopefully present a bit more details there when it's accepted, and there you can then come for the rest of the results. But to conclude anyway, or discuss a little bit, resistance training did not change the muscle strength. Maybe the problem was that the training was dynamically, the measurement was isometrically, so that we could not transfer to the measurement. Maybe also the measurement was not so used for these women. But the resistance training led to a significant increase of the cross-sectional area. That was 2.4%, maybe not so significant clinically, but it shows anyway a tendency. A problem was maybe that the intensity of the training was not high enough in all of these women, so we looked just roughly at these protocols. They noted all they did, diaries, and they did not much improve their resistance after the 6-week control. Many of them just stayed on the same level for 6 weeks, and so maybe they did not really go to their border and really go to the resistance that would be effective to get more muscles. But anyway, a bit more was there. Maybe when we would push them more, it would give even more. So small increase may indicate that strength training is a possible option. Maybe it needs a bit more guidance than we had, but it is possible, and it can lead to more muscle mass. The question, when we look at the other things, is then, does this also correlate with other parameters like the functional things and also the questionnaires? So for the future, we will evaluate this RCT data further, the additional measurements, the questionnaires, the follow-up. We are then looking, that's Christine's part now in the moment, looking to do some sketch trials, single case experimental design with one patient with a hypermobility syndromes and low back pain, because we have a low back pain program also where we have hypermobile persons often. So yeah, maybe we'll pick one or the other out to do such a trial with one person, and there also look at the movement control of the low back. So these movement control tests, this stability, mobility of the low back, and look at this and mainly at the back there, but also in the same part look at some more general things in the knee or whatever. That is in the planning phase, so we have not yet the protocol, but it's an idea to do this. Then we'd like to translate the questionnaire. That is one of our next steps, that we can use this in this trial and also maybe in the clinical setting. Then we have still ideas for biomechanical studies. Kinematics on stair would be very interesting, would be a thing. We have a stair, we have a kinematic system, so we just should put it together and find someone who does it. Also the ultrasound measurements we saw yesterday, we have ultrasound devices in the rheumatology, so maybe we could there do something more. And also an idea of also the rheumatologists, and for me is to maybe also do histological studies, so to look more at the connective tissue in these persons, to look what is there really the difference, and what is there also maybe with hormonal state, where there were some ideas, but these are more ideas and not yet finished. So there are many ideas, but also in Switzerland, only little time and money, but okay, we try what we can do. I thank all the collaborators and co-workers in this. This is our university hospital. It's called the Inselspital. That's the Isle Hospital. So it's this island where we are on. Truly, we are not on an island, but okay. Maybe sometimes we're a bit in an island of research. Thanks to the participants of the studies, thanks to the Swiss National Science Foundation and the University Hospital, and thank you for your attention. And so, what about your ideas?